Yes, thank you once more for the really interesting lectures. I had two questions, one of the last part, one of the part before the break. Starting with the last part, the Chiari malformations. I've now come across two patients who had a decompression for a Chiari malformation, and sometime after that, some months after that, developed acute orthostatic headaches. They were referred to me to rule out CSF leaks, spinal CSF leaks. We did extensive spinal imaging, myelography, found nothing. We rechecked the pre-operative imaging to make sure that these were real Chiaris and not pseudo-Chiaris that had been CSF leaks spinal all along, and we found nothing. Is this something you have come across, and is this something with a change in dural compliance postoperatively, or what is your idea about this and how to treat it?
I've come across that uncommonly, and the brain imaging was fine. Sometimes it's a question of it's a pseudomegacele leaking just low. But oftentimes some of these Chiaris are a little bit lower. When you do like a C1 laminectomy, some of that actually ends up being like in the cervical spine, the drop, but not there, huh? Okay. Yeah, it might be a compliance issue. I haven't really seen that at all.
Okay, thanks. My other question was about the obstetrics that were talked about before the break. Yep. My question is related to that. So pregnant women with spontaneous leaks. I get quite a lot of questions from gynecologists and anesthesiologists about some, I think 4 patients we've seen now were pregnant and have a spontaneous leak. Can they have a spontaneous delivery? What with all the pressure happening around there? Can they have epidural analgesia? So there's not a lot of literature about that, some case reports that show that's usually fine. But what's your experience with this?
Does anyone have any experience with this? No. I mean, from an anesthetic standpoint, I would say I would feel comfortable doing a small gauge pencil point spinal anesthetic on them, for sure. The issue of Valsalva, if they're symptomatic already, then they might not want to have a Valsalva delivery, vaginal delivery.
But in your opinion, it's not a clear contraindication, like a medical contraindication, right?
Not necessarily. I mean, that would be a perfect time for a multidisciplinary discussion, and that's what we actually do, because we have all kinds of different sort of fascinomas that show up when women come to deliver. And we have a multidisciplinary discussion about what are the relative risks and benefits.
Yeah, we did as well. And they, in the end, they delivered spontaneously and they were all fine. So
yeah,
in my humble opinion, very small.
Yeah.
And it's safe. But
yeah,
I was wondering if anyone else has more experience with this.
But what I learned from your presentation is we all have our patients in bed for 2 to 4 hours after the blood patch. And that's, for me, that never made sense. And now you showed, yeah, okay, they get better when they get worse when they lie for 4 hours. And the problem, or why I'm not convinced so far, is because we want to have the blood getting distributed along a long distance. And that is not if the patient's just lying flat and do not move. So they have to move. And for us, it could be a paradigm change, but we can send them immediately home. Any comments from the audience?
I mean, there's like, what you think is going on and then what is going on. And I think, a lot of times these recommendations we are based on what we think is going on because we don't have hard data. But I think one of the ideas is that when you're laying down, you're decreasing the CSF pressure in the lumbar spine. So if you're trying to seal a leak by putting the patient flat or even in Trendelenburg, you're decreasing the CSF pressure in an attempt to prevent. It's sort of like putting a lumbar drain in to get a cranial leak to here. You're decompressing the system. So whether or not that has any real effect or not, that's sort of
I have a question for Dr. Beck. The neomembranes that we all see during surgery, I always thought it was an inflammatory reaction to the epidural blood patch because it's reminiscent of the subdural intracranial membranes with the chronic, with the chronic blood mixing with the CSF causing an inflammatory reaction there. Do you have any thoughts on that?
Could be. I don't know for sure, but I personally think it could be an inflammatory reaction, but I rather think it's a reaction to CSF in the epidural space. When we do revision surgery, so unfortunately, we haven't analyzed the cases without any epidural blood patch before, but we do a lot of revision surgery after spinal cases, disc herniations, fusion surgery, and there are no membranes. And of course, there was always blood in contact with the epidural thread in the epidural space. And thinking to the analogy in SIH where all these membranes form, so I believe it's rather a reaction to extracetal CSF, and CSF comes into contact with epidural fat or space. There's something going on. Inflammatory, yes, but not due to the blood, rather to the CSF. But I think Florian Foltz has an idea.
May I comment on that? I'm pretty sure it's not the effect of the blood patch, the membrane formation. This was what I thought at the beginning as well, because it seems so logic. But we see the same membranes and even the same amount of membranes in patients with SIH that did not had one blood patch before. So it could not be the blood patch. It must be the CSF that's the problem, or that causes the membrane formation. For me, it's like the try of your body, like healing and patching itself, like in a simple-minded way of speaking.
Also, from a blood patch perspective, you would suspect that the blood spreads, which some data has shown over cell level, and the membranes are usually formed at the level of the post-dual puncture hole and adjusting to that, and then they stop. So that would be an argument against this as well.
The third argument in favor for not being, it's not the blood, is that usually the leak is never where we suspect it to be. It's almost always higher. So if the anesthetist, I don't know what's the mechanism, at least in Europe or in Germany, says he did a puncture neurology, so is it at 4, 5 or so, it's almost always 1, 2 or 2, 3. And this doesn't fit as well with the blood patch, with the blood theory. Hints, no proof.
As a response to what's happening in the epidural space, we often consider the epidural space to be a very simple space. It's not a space, it's a compartment. And we think it's filled with a sort of random array, at least we anesthesiologists, sorry. Maybe I shouldn't tell this in this esteemed audience, but as anesthesiologists, we often think it's just randomly filled with substances like fat, etc. But recently there were some papers that actually there is a sort of peridural membrane, and that the whole epidural space has a sort of synovium, a functioning response to friction and whatever. So maybe the membranes are a response of this epidural environment to damage.
Seems like a good question maybe for an animal model. I don't know if anybody has capabilities of doing that, but that might be a good way to answer this. You could do blood patches and take a look, or yeah. Okay, great. If there's no more questions, maybe we can move on to the next session. Thank you so much.